For my placement experience, I was working at Ipswich Town Football Club and I shadowed Bill Knowles at Knowles Athletic for a 2-week residential. My main objectives at Knowles Athletic was to meet and network with Bill Knowles, learn and understand Bill's philosophy of rehab, what is his training process and markers for progression during each phase of the rehab, why does he have so many rehab success stories. Whilst I was working at Ipswich Town Football Club, I wanted to learn and understand medical and physio methods to accelerate healing, how to plan and structure a long-term rehab, and understand when is the optimal time to start early stage rehab to the injured site. During my placement experience, I learned how early you can introduce hydrotherapy following injury and the multitude of functional movements you can perform in the pool. Bill doesn't utilize a traditional protective rehab approach that focuses more on the injury. He prepares the individual for athletic movements using a physical literacy model. He creates an enthusiastic environment and has a can-do attitude to build confidence in the athlete. And the key thing that Bill says is that just because you're biologically healed, it does not mean you're physically or mentally prepared. So also feedback from the athlete was that when he returned from the States, he reported that it was the strongest he's ever felt. The client in this case study was a professional footballer who returned to play in over 4 months that had an extensive rehab. So I have critically reflected the main rehab techniques that were outside my working remit in this presentation. The player suffered a grade 3C distal bicep femoris long head injury to his left limb that was diagnosed via MRI. The mechanism of injury was caused by sprinting. He has previously had a low-grade hamstring injury on the opposite limb 2 years prior. The player reported 8 out of 10 pain on the VAS scale during onset of injury and 3 out of 10 at rest. And he also had an abnormal limping walking gait. The head physio performed a passive straight leg raise to assess post-injury muscle length and an active knee extension test to assess hamstring muscle length and the range of active knee extension in the position of hip flexion. The player reported pain during onset and had a significant difference in range of motion between the injured and uninjured limb. 2.5 weeks post-injury, the head physio and specialist opted for surgery. The player was partial weight bearing and the knee was braced at 60 degrees for 2 weeks, 30 degrees for 1 week, and the brace was removed and the player was full weight bearing 3 weeks post-surgery. In a recent study by Pollock and colleagues, they reported that tissue healing times for C-grade tenderness injuries to be between 2 to 4 months and return to full training between 3.5 and 10 weeks in track and field athletes. However, they didn't state if any of the subjects required surgical intervention, which would have increased the healing time. In our case, we opted for the 4-month return. One of the main objective strength assessments we performed was the Kanga supine claw, where he performed a maximal voluntary isometric contraction in this movement. So resisted isometric testing is a convenient and clinically useful technique to detect neuromuscular dysfunction and to track the progress of patients as they undergo rehab. So the reason why we perform the supine claw is because it's a similar position to the strike position during sprinting. And then, as you can see on the slide, we did we had a pre-injury score and then his 11-week post-surgery score as well. So his left, so his injured side, is lower than his pre-injury score. However, it's within 90%. So we were happy with that. And then also his asymmetry between obviously left and right was less than 10%. So we were happy for him to return to play. systematic diagnostic ultrasound was performed during the rehabilitation to inform decisions for the medical team to know when to progress the athlete during the rehab. So the key times were the 3-week ultrasound review, which shows good muscle healing and scar tissue formation, increased blood flow to the area, and therefore the decision was to begin rehab to the injured limb at that stage. The next was the 10-week MRI review before we were planning on getting him out on the grass doing more kind of football activities. So this scan showed good evidence of excellent healing response compared to the previous image, and then tendon is in complete continuity and with normal tension. There is no defect, and then there was good evidence of fibrosis at the tendon, which is consistent with the ongoing healing. So research has shown that diagnostic ultrasound can offer a fast and non-invasive way to diagnose soft tissue injuries. Also, systematic ultrasound scanning will provide objective feedback on the status of healing to inform us when the appropriate time is to progress the rehab. There were a number of early management treatment strategies that we performed with this player. However, I wanted to highlight the use of neuromuscular electrical stimulation to accelerate healing. The reason why we used electrical stimulation was to combat arthrogenic muscle inhibition. So this happens when you get an injury. It's a depowering of your neuromuscular system. Look at it like a dimmer switch when you get an injury. If left unresolved, this can delay or even prevent effective strengthening during return to play strategies. We performed electrical stimulation to the player's quads, hamstrings, and calves early and often post-operation on the muscle stimulation setting, 1 week and up to 4 months post-surgery, and we progressed intensity that was tolerable. The reason why we did it is because contractions are forced by the motor nerves to stimulate the muscles involuntarily. We can also stimulate the type 2 muscles with no stress to the injured site. In reflection, we could have implemented exercise with the electrical stimulation, not just passive treatment. Another treatment strategy we used to accelerate healing was active cryotherapy and intermittent compression using a game ready. The company claims there is clinical evidence that has shown to help decrease pain and swelling. The results from these studies is highlighting the acute analgesic effect and consistent reduction in pain. Importantly, controlled trials implementing its use following musculoskeletal injuries do not exist, so evidence in support of its use for accelerating recovery following injury in humans is equivocal. 3 weeks and beyond post-surgery, we started hydrotherapy techniques in the pool, initially performing deep water running with the neck immersed and floats in each hand to increase buoyancy. As shown in the image on the slide, 90% of body weight is offloaded in neck deep water. Therefore, the athlete can train the neuromuscular coordination of running with minimal load on the joints and muscles. Throughout the hydro rehab, the player performed specific movement patterns such as running drills, pool plyometrics, and scissor kick. kicking. Intensity was progressed by reducing immersion depth, varying speeds, lever lengths, range of motion, and repetitions. Hydrotherapy was utilised to build confidence in the athlete early, restore athletic movements as fast as we could, and regain neuromuscular coordination and reduce muscle inhibition. The three main hydrotherapy principles are buoyancy. As mentioned earlier, the more the body is immersed underwater, the greater percentage of body weight is offloaded, which is significantly important when it's too early to start running and perform athletic movements on land. Secondly, the use of hydrodynamic resistance. In other words, the resistance of water when your body and limbs move through it. And finally, hydrostatic pressure has been reported to reduce pain and edema, increase range of motion, and enhance the cardiovascular system. 7 weeks post-surgery, the player went on a 2-week reconditioning camp with Bill Knowles in Philadelphia. And Bill has 4 pillars to reconditioning. Number 1 is long and strong. This is by optimizing muscle contraction via the length-tension relationship. So this image in the top right corner is a great example where he's doing like a kind of kicking action on the Kaiser cable pulley machine. He's in hip flexion, so the hamstring is lengthening at the proximal end of the hamstring, but is also in knee extension, so it's lengthening at the distal end of the hamstring. So the hamstring's at full length, full stretch, and he's also holding the poles. That was to keep the posture upright and an ability to brace the core at the same time. The image below, the athlete's performing a single leg hamstring curl on the Swiss ball. So this requires high amounts of stability and neuromuscular control to stabilize the movement, as well as eccentric hamstring strength when he extends his knee. So he's strengthening definitely the distal hamstring, and also he's in hip extension, so the glutes and the proximal hamstring will be contracting isometrically. So we've got more hip dominant movement at the top and a more knee dominant movement at the bottom here in this slide. Why? Because eccentric hamstring strength training at long muscle lengths has shown to reduce reoccurrences. What I've also reflected from the experience with Bill is that he doesn't perform any high force exercises with external load. Obviously he used the Kaiser, but other than like say the barbell RDLs or dumbbell single leg RDLs, exercises like that, he doesn't perform. So that no high force mechanical tension on the hamstring weren't performed, so which is very different. Bill's second pillar of reconditioning is hip mobility. Poor range of movement can cause excessive load onto other structures, as well as movement deficiency. On the slide in the top right hand corner, you can see the player performing a 90-90 rotation or pretzel movement. So the player is going into hip external and internal rotation. So he's really trying to open up that right hip as much as he can, as much hip external rotation, whilst keeping the left knee down. And then once he gets to his as much range as he can, he goes into hip internal rotation on that left side. The image below, he is performing a hip mobility exercise with the sliders. So on the right side, he's really trying to reach and push the slider out, so going into hip extension. And then on the opposite side, he's in deep hip flexion and hip external rotation, and he's making kind of big sliding circles, so he's mobilizing that hip joint. Performing hip mobility exercises is important because restricted hip mobility can cause muscle imbalances and affect the whole kinetic chain. Bill's third pillar for reconditioning is gait re-education. A range of mechanics drills were performed at low intensities to increase neuromuscular efficiency. So on the slide in the top right-hand corner, the player is performing a wall drill where he falls forward and throws his hands in front onto the wall, where he requires to brace that core and then switch his limb in like an acceleration position. So he has to co-contract both his hip flexors on the left side and his hip extensors on the right side in this image. So he's in triple extension, ankle, knee, and hip, and triple flexion. In the image in the bottom right, he's doing a dribble run on the gymnastic flooring, so like a soft sprung floor, which will reduce the load on his joints compared to a land-based training. So he's working on being stiff, working those movement patterns that he would do out on the pitch. These were progressed to develop physical qualities needed to prepare for running, accelerations and decelerations, and change direction. So working on those qualities such as leg stiffness, like mentioned before, storage and return of elastic energy, and rate of force development. So the reason why we worked on this is because alterations in gait pattern occurs following injury to protect the injured site. Bill's final pillar for reconditioning is co-contraction and bracing. So performing coordinated movement patterns similar to running, acceleration, deceleration, and change direction tasks. So this image on the slide in the top right hand corner is a great example of a more coordinated pattern than the one in the previous slide. So he is in more of a trunk lean this time, so more obviously acceleration position, but he has to co-contract again his hip flexors on the left side and his hip extensors on the right side. And with the hand, he's holding that position for at least a second or two. With his hand on the box, where he has to obviously brace his core, resist any rotation, and then it goes into a step up knee drive on the box. So again, requiring that co-contraction around their hip flexors and hip extensors. In the image at the bottom right hand corner, the player is performing more of a bracing drill where he's on the gymnastic flooring and using the sliders, where he's leans back, puts his hands on the floor kind of into like a V-sit position, bracing the core, and then splitting his legs out wide and then going back to the start position where his feet go in. So it's kind of a dynamic movement, feet in, feet out, rock forward, rock back, requiring that stiffness around the core. The reason why co-contractions are so important is because co-contractions of the agonist and antagonist muscles reduce muscular effort, resulting in improved running efficiency, and also enhancing core stability during static and dynamic tasks is likely to mitigate the risk of lower limb injuries.